Welcome to our COVID learning series for long-term care. Emily and I have put together this series and we're on our second session this week, and we're going to be talking about preparedness and containment. So how to prepare for an outbreak. And of course, given the circumstances with our outbreaks in long-term care this week, I think it's a very timely discussion. So happy to see so many people on the line. For those of you who don't know me, I am a long-term care manager and have been supporting the team on the third floor at Aberdeen with a lot of the COVID management strategies, guidance documents that you've seen coming out, and have a background as a nurse practitioner. I want to take a moment and remind you, though I'm sure Lisa's already just let everybody know, the session is being recorded and will be made available afterwards. Last week's session is on the intranet. I'm still trying to get it onto the internet, so still working out some of the kinks there. I want to take a moment and just acknowledge that I'm a visitor working on the traditional territory of the Lekwungen speaking people, known as the Saanich, Songhees, and Esquimalt people. So I just want to encourage everyone to take a moment and reflect and acknowledge the land that you're joining us from. Really appreciate everybody taking time out of their busy day to come join us, and whether you're here today right now or you're going to be listening to the recording afterwards. The purpose of this series is really to build confidence and be able to share anecdotes, share supportive stories and insights about COVID management, making sure that we can help everyone prepare as best as possible in their facilities to feel that they're working with the most current knowledge and information and safely during an outbreak. I also want to take a moment and just acknowledge all of the leaders on the line, but also all the frontline staff who, you know, this has been a really challenging year, and we really appreciate all of the measures that you're taking right now to ensure the COVID safety protocols are being followed, and for the safety of the residents, but also for your colleagues and each one of us. It's really important to make sure that even though we're tired, I'm exhausted, and I'm sure everybody else has had those feelings, but we want to continue to make sure that we're upholding those safety protocols, especially with the restrictions that were discussed by Dr. Henry yesterday, limiting those social gatherings, so not having any of the social gatherings, but limiting to interactions within your household, making sure that we're doing the hand hygiene strictly, and adhering to PPE and mask wearing. It's really important that we continue doing it, because though we're potentially nearly towards a vaccine, we're not there yet. And so really want to thank you for all your tireless efforts, and know that you really are the best defense in preventing COVID and getting to the building. So I'll stop talking now, and what I'm going to do is introduce our primary speakers. We have Marina Lang, who's one of our clinical nurse educators in long-term care and one of our COVID resource coaches, who's had the fortune of being part of our most recent outbreaks. She comes to us with a Bachelor of Science in Nursing and Advanced Certificate in Critical Care. Throughout her nursing career, Marina has worked in a variety of clinical settings, including psychiatry, med-surg, emergency, ICU, site operations, and forensic nursing. She's a lifelong learner and enjoys opportunities to engage with and learn from her colleagues. She's excited to be here today, and we are very excited to have her. Lauren Robinson is our other primary speaker, who comes to us from Alberta with an undergrad degree in cellular, molecular, and microbial biology and a master's in public health from the University of Manchester. She's worked in several portfolios in Alberta Health Services, including diagnostic imaging, contracts, and continuing care. And she's been with us at Island Health for over the last 5 years, and loves her time on the island. Has a beautiful little daughter, Willow, and her lovely husband, and is now expecting a son any day. Alongside our main presenters, we also have Dr. Enns, Charmaine Enns is one of our outstanding medical health officers who's been supporting the most recent outbreaks in long-term care. We also have Ben Shaw, who is an infection control practitioner who's been working with our long-term care team, developing, reviewing guidance. Lisa Young, who has the most colorful background, has been fearlessly enacting the role of Director of Infection Control and Prevention, and so supporting all of Island Health with COVID management. And you'll also see my beige wearing colleague matching me, Dr. Manville, who is our wonderful long-term care director. So I'm going to throw it over to Marina and Lauren, and please begin the presentation.
Thanks, Bevan. Thanks for the introduction and welcome, everyone. So today I'm going to try to go pretty quick over my segment. I'll be talking about the containment plan, which I'm not sure how many of you have seen, but I've pulled out some components of it to give you an overall idea of what it contains. And then Marina will go into a more site-based specific approach.
And sorry, Lauren, just so you are aware, we also have Dr. Fife, Murray Fife, one of our other wonderful long-term care medical health directors, or medical health officers, MHOs, that's been helping long-term care. So he's on the line as well.
Perfect. Welcome. Okay, so I'll start off talking a little bit about the containment plan. So the reason for developing the containment plan was so that it would be kind of a source of information and it would have something for everyone. So it's certainly not a toolbox for applying to your particular site, but it'll certainly give you links to some of those tools to help you get started. If you do go through it, you'll notice that it's geared toward a variety of staff, whether that be folks in leadership or folks on the front line. It has a lot of the resources in a single location, or at least links you to where to find those, because a lot of our folks on our team have worked really hard on creating various guidelines and procedures to help folks get through this time. And so it's a good place to start if you're not sure of where to find something. And it provides an overall picture. So what we're learning, and what we've heard from other jurisdictions, is that no one case is exactly the same. So, it gives you an overarching view of what might an outbreak look like, and encourages you to think about how that might affect you and your staff and your residents at your site. So an overview, it's divided up into 5 segments. So it gives you containment options. So takes you through a decision support tool. And then it goes into planning, communication, learning and evaluation, and a site-specific approach. So I'll go through each of these in a little bit more detail. Beginning with containment options, there's essentially 3 main options available to us. So it's caring for our residents on site, transferring them to a hospital-based COVID-19 cohort unit, or transferring to the emergency department for urgent treatment. So those are, in a nutshell, the 3 main options, and that could change, but that is what's available to us, at least at the time of creating this document. And the destination and selection of any of these 3 options is based on a number of things, and it's hard to pinpoint exactly what the trigger is for any one of these, but it does take into consideration multiple factors. So what is the number of symptomatic folks or confirmed positive residents? What's the exposure and what's their acuity look like? Are kind of a general, and there's questions in that document that will take you through each of these different factors, and how people like Dr. Fife and others would determine what's the best option for the resident. So for planning, in the document, we went through a list of items that sites might be in need of. It includes resources, so talking about COVID coaches that might be useful in an outbreak. So it's good to consider ahead of time. There's other things in there like PPE. Do you have enough PPE? And it also prompted us to think about what would sites do if they didn't have enough blood pressure cuffs on site. And so internally we've looked at, do we have enough supplies on hand, and what are our options for securing things in the event that isn't enough, and how do we do that quickly and efficiently. But if I were on the front line, I would take a look at that list and just take stock of what you have, and certainly not encouraging stockpiling or anything like that. And know that we have a process in place in the background should access to those items be a challenge. So the next component is communication. You might be wondering, in the event of an outbreak, who talks to who, how does the actual containment plan get activated, that kind of thing. So it provides a link to the response plan, which is on the intranet, which will take you through in detail what it looks like from somebody under investigation to a full outbreak and so on. It breaks down leadership roles, so who's responsible for what, and how do we actually activate some of the components of the plan, and gives you a brief list of who's responsible for connecting with who. So you might be wondering who connects with families, that kind of stuff. So it'll give you a general idea of who is responsible for connecting with each of the stakeholders. So one of the most important things is learning from all of this experience and giving ourselves the opportunity to evaluate it. So we've designated this document as kind of a living document. There have been conversations with other health authorities who have experienced outbreaks. And so trying to take what we can from that and put that in our documents so that we're aware of what learnings we can get from others. But there's also the learnings we can get from things that we've been doing. So Emily and Bhavin have been leading a number of simulations, and they've created a table to help us identify what our learnings from those simulations have been. And then there's also, the documentation we take down from our emergency outbreak calls and incident management meetings that are valuable and contain valuable information about how we've handled things and where we can improve. And then lastly, and this is a good segue into Marina's component, are site-specific approaches. So there's a diagram that I know that she'll go through in more detail about what red, orange, and green zones look like in long-term care. I know that there's been one circulating, and it can seem that it's a little bit acute care focused. So we have one that's based on long-term care. You can learn what a resource coach is in the event that you don't have one or haven't interacted with somebody. That is a resource coach. Talks a little bit about that role. There's also a list of all of the sites on the island, including private sites. You might want to look in there to see if there's someone or a site in your area that's similar to yours, and potentially you could collaborate with them about what their plans are and see how it relates to yours and your specific circumstance at your site. It talks about the response plan. So response plan are essentially a pool of staff that have identified as volunteers to be redeployed if that's what's necessary. And it talks a little bit about what their orientation looks like and how that whole piece works. And then where can you find additional resources? So there's a list of links at the end of the document that will take you to a variety of sources of information that could be helpful for you to review. So with that, I'll pass it over to Marina and I'll stop sharing here.
Hi there, I'm just gonna get my screen up. So first of all, I'll say from experience this week that I put that containment plan to good use. So thank you for all those who were involved in making it. And I'll probably go a little bit rogue here from the presentation because we've got some great panelists on here, and I think we'd like to discuss more about what we've learned this week and in a more practical aspect. But first I'd like to start with why the preparation piece is so important, and it's because we have had the opportunity in BC, in Island Health, to learn from the experiences of others. And to be able to build our containment plans and work on our long-term care response protocol based on that learning. You'll see on the slide here some of the key learnings there were the prevalence of asymptomatic spread, That lapse of PPE use and hand hygiene can be a contributing factor to transmission. So for the same reason why we're putting why we wear our PPE, it's just as important as how we take it off, and making sure that we are modeling the best behaviors that we can, whether we're frontline workers or leadership, showing these practices and making them visible for people to learn from and model from. Social distancing in staff congregate areas has been linked to outbreaks and transmission. So if taking a look at your site and looking at areas where staff do congregate, and how physical distancing can be employed in those areas, whether that means removing chairs or marking chairs or having specific seating, we need to remember that physical distancing is the highest level of control, and that while wearing masks is another layer, it doesn't negate the need to still keep ourselves distanced from each other. Other things that are sort of static and unique to each site are your number of residents and the layout of your site, as well as if you have single rooms or multiple room occupancy at the site. These are all considerations, and these are sort of concrete factors that you need to be aware of how they influence your containment plan, because you're not going to be able to change those, but you're going to need to know how to work within them. And as Bhavin mentioned in the beginning there, we do have a certain degree of personal responsibility right now with the given the most recent public health orders. And these are the mainstays of really how we keep ourselves safe, as well as the people that we work with. And I do find when things start sort of escalating, grounding yourself in the basics of hand hygiene, mask wearing, eye protection, and physical distancing can really help bring down anxiety, knowing that those staples have been followed through on. The long-term care response protocol, I believe that's going to be going into detail in another series maybe next week. But the sort of the mainstays of this document are the importance of early recognition of symptoms. So having a very low threshold for recognizing any changes in ourselves as staff members, as well as in our residents. Knowing that residents in long-term care, we may be working with people that can't describe their symptoms to us. So being aware of any change in baseline behavior could be a sign of early possible transmission or disease process that we need to be aware of, and start those droplet and contact precautions rather, and early swabbing. Early isolation and timely testing are huge. So early isolation of a single resident or person under investigation is the very first stage of your containment plan. And is a way of communicating to all staff how to enter and stay safe while caring for this resident until test results are known. Timely testing, being able to get that nasopharyngeal swab done as soon as possible and sent to the lab. We do know they are experiencing higher levels of testing, and really a lot sort of comes into play while you're waiting for those test results, and informs actions after the fact. You're going to hear me talk about this a lot, but communication, communication, communication. How we communicate with our teams, how we communicate with the long-term care response team, how you communicate with your families. Now is your opportunity to really look at your communication aspects, and how, if you can streamline your communication processes, whether it's with an email distribution list for your staff, having an up-to-date contact list for your residents and their families is really important, because making sure the correct information is out there at the right time really can help build confidence. It streamlines messaging and can help with anxiety and fear that everyone will be feeling. This is just a quick look at the long-term care response protocol. Again, there will be a presentation on that next week. So as Lauren mentioned, there are outbreak zones that have been adapted to long-term care, and really taking a look at your site, because all of our sites are unique in how they're built and how they're staffed, and the flows and how things move in the sites. So the outbreak zones in general, they identify areas, and they're coded green, orange, and red based on the viral load in each area. And then across the document are arrows saying how to transition safely between each zone. With those transitions, they also identify the PPE that's required to move, say, from a green zone to an orange zone. Regardless, red is always droplet and contact precautions, which means you're wearing your full PPE, and when you come out of that residence room or that red zone, if it's outside of the residence room, that your eye protection and mask are being changed at that time, as well as doffing of all PPE. This is just a quick snip of that outbreak zone document. There was a few things here that can pose some challenges. So, and it's something you can work with right now, that you don't need to wait to find out where a positive resident may be at your site, is play it out. Look at your site plan and say, you know, if I had a resident here that was positive, what would this mean for my site? Can I break apart my site? Can it be divided or cohorted into a unit or a zone or a floor? How do my staff move through this site? Do I need to look at particular staffing for that area? When staff are coming in, a big learning here was that staff need to bring, as you can see in the orange zone, and in many cases, because of how much fluidity there is in long-term care between residents when they're eating in congregate areas or attending activities in congregate areas, as well as with how staff flow, it's reasonable that a lot of the site will be considered orange. When you have an orange zone, you are wearing a surgical mask and eye protection in that zone. So in order to enter safely into that zone, you need to have masks and eye protection on the outside in the green zone. Staff as well are recommended to be able to change into clothes at work that they wear for the duration of their shift. So a practical aspect of that is, do you have a place for staff to change, or what would that look like, and where would they store their clothes so that they can bring their items home safely to be laundered at home? This was something we did find communicating to the next shifts coming up was important too, so that they were aware of what they could do to make things smoother when they were on shift. I think I'll move on from there because I'd like to hear from our panelists. When you're thinking about your site plan, the people that you're considering are staff and residents, indoors and outdoors, depending on how they flow, and if something's cordoned off, can people have access through the outside that you may not have anticipated? Looking at how your food comes in, some of the reality is that your significant areas of your site may need to be on tray service. So what does that look like for getting the food to those areas who may need to eat in their rooms on tray service? Do you have enough trays? Do you have enough disposable utensils and plates if that's what you're going to be using? Looking at your supply chains for what's coming in and what's going out, and if there's ways that can be changed just to avoid transmission zones. Probably, so this was written before some recent experience, but these tips still stand true. When you're looking at these documents, whether you're in leadership or if you're a frontline worker, walk through the steps at your site and turn those processes that are on paper into practice, because you're going to find out little areas that might be a bit of a stumble, whether it's how you get your PPE or where you store it. Is that a practical spot to happen? Do staff know where your isolation carts are and how to get them? Is the signage ready? Making things as streamlined and easy as possible is really important, because these little stumbling blocks tend to build up along the way, and if you can mitigate them before you need to use them, that just makes everything a lot smoother. By looking at your site, looking at the outbreak zones and sort of running through some different scenarios, you gather a really great understanding of your site so that you know your strengths. And when it comes to the emergency operations management teleconference, which you would be attending, you're able to advocate for any gaps and be able to seek help and support from that. And I can tell you that there is so much help out there that although it may feel lonely and scary, there is a giant team out there and they're working their butts off for you. So make sure that you know that and how to connect with them through that EOM at the initial call. when you're doing your planning, however you can involve your frontline care staff is important, because as we know, a lot of these things happen after hours or on the weekend, and things change depending on what time of day that you may be addressing some of these issues. So the more people that are in the know and the more people that have a practical knowledge of how these processes work, the better. I'll leave it there, and then Bhavin, do you want to open it up to our panel?
Yeah, thanks so much, Marina and Lauren, for sharing that. In terms of the containment plan, I believe it has been circulated out in email. We are looking to put it onto the intranet if you'd like to get your hands on it and somehow got missed in the initial email. So yeah, talking about the giant team of people supporting you, whether it's during the Monday to Friday or not, we have processes in place that we're going to be gathering and linking together. Everybody's in this together. So yeah, that's a great point. I'm curious to the panel. So Drs. Fife, Dr. Zen, Dr. Manville, Marina, Ben, Lisa, what do you think from this week? So just a quick summary, we've had 2 outbreaks, and unfortunately, they've been with healthcare members that have come in, and frankly, the healthcare members did everything that they should have in terms of booking off at the time that they should have. So they did everything right. And I think, you know, they tried their best to prevent it, and that's just the nature of this virus. But I'm curious from your perspective, what have some of the challenges been this week? And kind of reflecting on it, what tips could you give our long-term care operators around making sure they're prepared? And I'll just throw it out to whoever would like to take that question first. Dr. Hens.
I can start, Bevan. It's Charmaine Enns. Hi, everyone. And I'm going to look to my colleague, Dr. Fife, to fix what I didn't do quite right. So one of the things that's interesting, and I just want to expand a little bit, Bevan, on what you just said about the 2 staff. So the reality is, when someone tests positive for COVID, in our public health follow-up, we determine the infectious period based on the day the symptoms started, going forward, and then going forward 10 days. But we also go back 2 days from when their symptoms started, and we include that in the infectious period and as part of our contact follow-up. We call that the pre-symptomatic period. We only know that because we look backwards. And so I want to emphasize it for both of the staff. Both of them had their exposures in their respective facilities during their pre-symptomatic period. So while that's out of our control, I think it is just a gentle reminder for all of us that with that precariousness of an infectious period starting before we have symptoms, that we as staff and as people involved in healthcare, as much as possible, limit our mobility and our socialization so that we have less likelihood for being exposed outside in the real world, in our communities and in our everyday living. And that there's no blame at all for either of these staff, but this is about the opportunity for us to just hunker down more, to stay closer to home, and that will mean life is not as fun, but it'll also mean we have less likelihood of impacts in where we work, where kids go to school. And this, you know, I'm just going to be real here. The next couple months are not going to be easy in terms of our lives being normal. It's not going to be normal. So that's the context of, and unfortunately we have to use the word outbreak. That's also an upsetting term. I recognize that, but one case is one case too many associated with our long-term care facilities, and that's why the response and the containment is so aggressive, and that's why also that terminology is used. So I just want to provide those comments, and I look to my colleague if he has anything else to add. And to Lisa, yeah.
I have nothing to fix with what you said, Charmaine. I totally agree. I just want to start by saying thank you to Lauren and Marina. I think you did an excellent presentation and covered all the essential components. And yes, really want to congratulate you on that. And I completely agree with Bevan's open comments and Marina's comments and Dr. N's comments right now, that we all have a responsibility at this point in time to reduce our social contacts. That's really the only way that we can prevent introduction into our facilities. And so I think it's a really good idea right now for all of us to be talking with our staff about the responsibility that we collectively have to protect ourselves and to protect our clients and residents. I think in terms of Bevan's question about challenges, one thing I think is just to sort of think through what this might mean in your facility. Do you have enough, or do you have a plan to get swabs? Because we're probably going to want to swab a lot of people in a very short period of time. And we need to think about, do we have enough of the supplies available? Maybe not right in the facility, but where can you get them from? And also who could actually do that swabbing? So just sort of think about that, because that's going to help us to determine what's going to happen in the coming day or two after the first case is identified. So that's one challenge to consider.
Thanks, Marie. And just on that, Marina, I was hoping you could share that was one of the questions about, there is going to be likely a lot of people that are swabbed in terms of the testing strategy. Can you comment on the challenges about labeling and making sure all the requisitions are up to speed?
So in this case, there was a bit of a workflow system set up. We were lucky enough to have a public health team join us on 2 occasions to help perform the swabbing for both the site and staff, and having a very organized system of requisition completion, reminding that you do need the name of the long-term care facility in the CC to be able to receive the results in a timely manner, as well as ensuring that your personal identification indicators are correct for the person that's being swabbed. Doing those double checks are really important. There were a couple instances of mislabeled swabs that had to be followed up on. And then making sure on those requisitions and on the swabs that they're labeled long-term care outbreak, so that when they do get to the lab, they can be given a priority. The other piece I just wanted to go back to, because we were kind of talking about the first case being a staff member, and that has a couple extra challenges as well. When we have a resident who's first identified as our person under investigation, you have a bit of a window of opportunity to start planning what that would look like at your site, because you know where and who the person is, and you can start sort of working through their contacts and going through a lot of the points that we've mentioned here. When it's a staff member, you don't have that same heads up, because what's happening now in real time is that people are receiving their swabs in the community. They're getting them immediately to their phones. And so the person is the first person to be aware of their test result, and you may not had any idea that they were even getting tested or had symptoms. So this means, and this was probably the most uncomfortable time, was knowing that there was somebody positive, and that sort of the rumor mills start, and there's communications that are happening around, and it happens quite quickly, while you're planning and getting all the information you can to be able to share the information with the staff in the site, with the plan and the containment and the process moving forward. Communicable disease, and I think Dr. Enns can comment on that, does follow up with all positive cases. There just may be a lag or a delay between when the person gets that instant result to when communicable disease can make that phone call.
Mm-hmm. Thanks, Marina. I think that's, Dr. Enns, Dr. Fife, if you could comment. We don't have one of our CDE colleagues on, but just in terms of the process, what happens when someone is a staff member might test positive? I think that would be nice for people to hear, because I think, like Marina said, there's some anxiety about, well, what happens? Do we shut the whole facility down? And, people want to jump on it, and people are eager to protect the residents. I get that. But if you could speak to a little bit of what is the process when someone's tested positive, and why there might be a little bit of a delay.
Sure, I'm happy to address that, but I'm just looking to Lisa. Was there something you wanted to comment on before I answer that question?
There were just a couple of things. Thank you, Dr. Enns. Really just to pick up on that pre-preparation piece, really being very vigilant around the PPE piece within the facility. While we do get a lot of community spread, or there is the potential for community spread, if we can keep within the facility safe, then it puts us in a safer position. And I think Dr. Enns may touch on this piece when she speaks, but also again to pick up on a little bit of something that Marina is gonna just touched on there, is there is the rumor mill, and there is a lot of things spoken about when we do get somebody that is a member of staff comes up as positive, and we really need to be very respectful of them and respectful that they are going through a very difficult time and a very hard time when they get that result. We need to be respectful of their privacy, and I think that's something that as healthcare workers generally we need to be aware of, and not share their circumstances, not share what's going on in outside of some of the meetings that we're at, but also not share some of the information even in meetings that we're at where we don't need to share that information. So those are just a couple of things that I wanted to touch on.
Thanks, Lisa. So I'm going to, Bevan, should I answer that question? Okay.
Yeah, sure. Yeah.
So thanks everyone. So the process when we have a positive case, and as has already been alluded to, there is now a nuance for us in that people who have a positive test are texted their result as soon as it comes out. So what's happening is people get the text and then they forward it. I don't know, like it immediately goes into some type of social media rumor mill hyperspeed. So that makes it a little bit hard. But you know, we don't respond to social media. We respond to our process and to having a positive case. And of course, you know, I know all of us as healthcare workers, we're going to be diligent in our role as healthcare providers. We're going to be professional, we're going to protect confidentiality, and we're going to just respond to the facts. So I want to give you the facts so you have some confidence in us, hopefully in public health, that we have a process that works. We get a case. That case is then assigned to, it will, for anybody that's a healthcare worker or associated with a facility, it will go to a communicable disease nurse. That communicable disease nurse will reach out to that positive case and will do an appropriate case investigation. It will be a shortened case investigation if we have indication early that there is a link or a potential exposure with a long-term care facility to get the ball rolling. But that case investigation does two very important things. It determines the infectious period of that individual. That infectious period is critical for us being able to do contact follow-up. Once we understand the infectious period, then we can identify close contacts with that case. And then if it overlaps into a long-term care facility, we of course have that component of the follow-up, but we also have the other close contact follow-up that may be separate and independent from the facility. So, we can't conflate those two. We will do our job for all of those close contacts and doing all that follow-up. If we don't contact you, that's good news. So, you know, you don't have to go looking for a contact to a contact. I had lunch with them. Don't worry about it. It's background noise. If you were identified as a close contact, we will be tracking you down, I promise. So that process can take, depending on when our lab result comes in terms of identifying all of the close contacts outside of the work site, that might take us till the next morning if we get that result in the evening. And then of course, all of our cases and all of our close contacts, we follow up daily in public health, and they're monitored until they've completed their isolation or their quarantine period. So it's a pretty extensive, labor-intensive process. We take it very seriously. And then we get people asking us, am I a contact of, and I said, did anybody call you? No, well then don't worry about it. So we're not going to confirm or deny, we're not going to breach confidentiality, we're going to protect our cases. And all of us, I can't imagine how it would feel, no fault of your own, to be the person who is the case, the index case, and now your facility has an outbreak. That's not a good feeling. So we need to, I'm appealing to all of our professionalism and our standards of care as professionals, that we not text at work, we not send off these messages, we're careful that we don't disclose who people are, we don't refer to it by name, but refer to it as a case, and that we just continue to then we can all pull together to get the job done. So does that answer the question, Bevan?
Yeah. Yeah, absolutely. Thanks, Dr. Enns. There's 5 minutes. I have 2 questions that I'd like to ask. And one is off of what you just said, Charmaine, about, I think even in our recent experience, there was a lot of staff angst about, you know, the safety of coming into work because of potential exposure. And so I'm curious about, to Charmaine, Murray, Lisa, Marina, Ben, what should the message be to staff when they find out, like what should we be telling them in terms of the exposure piece and the safety around coming to work? Like, when should someone actually be concerned? Because yeah, sometimes there's a delay in being contacted, but you know, the safety piece, it is safe to come to work.
Yes, well, I guess I'll start. Yes, I agree. So I think, you know, the very initial phone call that we have with, you know, between public health, long-term care services, the facility, communications, one of the first things we look at is making sure that everything is as safe as it can be in the long-term care facility. So all the safety protocols are put into place, including the use of PPE, extra cleaning, making sure that any residents that might have been in contact that we're testing to make sure they're not a case themselves are under appropriate isolation precautions. So I think all of these steps are indeed doing everything we can to make the environment as safe as possible. And I think the other, you know, good news about it is the work that everybody is doing to test very quickly anybody that has symptoms, both their residents and staff doing that. We're picking up things very early. So the chance of there being extensive spread, the chance of there being a lot of virus around the facility is very, very small. That's not only the case here in Island Health, but that has been the experience through most of the, what we're calling outbreaks, quote unquote outbreaks, where there's one staff person, for example, that has been positive in a facility in other areas of the province. And it really has not spread very much beyond that. So I think that we should be able to reassure our staff that it is a safe environment, and we just need to follow the protocols that are put in place.
I could just add that it's a really good time to go to the basics. And so all of the practice that the staff have been doing with donning and doffing PPE, wearing masks routinely, those measures we're seeing over and over again that they're very effective. And that if you need a little bit of practice or some feedback on those, on donning and doffing, or if you have questions, that to reach out and make sure that your practices are good, and to trust that they're going to keep you safe while you're working.
You know, I think that, Ben, that's a really good point. And, you know, we have these discussions with schools when we have a school exposure too. You know, there's so many layers of protection in our facilities and in our schools. So, you know, the fact that there's a case should not mean any, you know, we need to keep coming back to what we know, what we've been practicing, and those multiple barriers all make a difference. So it starts with not coming to work sick. It starts with your, you know, your procedures that you use within your facility all the time. You're doing the physical distancing, you're masking, and you're not slipping on that when you're in the break room or having lunch together, you know. So, and then of course what we do outside of work to make sure we limit our likelihood of exposure. So all of those things, it's not all held, it's not one thing that makes a difference. It's the accumulation of all of those things that provide a healthy barrier. And again, most of our close contacts, even within households with a case, do not go on to become go on to become somebody who's infectious. So I think there should be some reassurance there. We need to keep coming to work. We need to keep doing what we're doing. We need to keep it in perspective and keep applying all of those multiple barriers so that there's no Swiss cheese effect.
Thanks, Dr. Enns. I think that was actually a great summary of what we need to do in terms of preparing for an outbreak, and emphasizing that prevention really is the #1 strategy that we have, and everything we can do in that instance is really what we'd like from all our operators and our staff, but also have some reassurance. We have some processes in place. Our leadership team is very comfortable with managing the outbreak, and I think a lot of the preparation we did over last few months have shown in the outbreak management that we had to undergo this week. We want to take a moment. We've come to our end of our time. So thank you so much to Lauren, to Marina for your excellent presentation. Lisa, Ben, Drs. Manville, Enns, and Fife, thank you so much for being on the panel here. If you have a moment, there is a survey that we have, so Emily and I can continue to work on improving the series. It's in the chat box. We'll have our next session next Friday at the same time, and we'll be talking in more detail about the response protocol and having, again, some of our panelists here to discuss that in more detail. Thank you so much, everybody. Take care and be safe. Thanks.